The movement to value needs a strategy shift. Providers and payers have struggled to find common ground for more rapid adoption of advanced alternative payment models. In this session, understand how value-based care experts are envisioning the future of advanced alternative payment models and the strategies that payers and providers must pursue to achieve long-term sustainable adoption. Francois Desbrantes, the Senior Vice President of Commercial Business Development at Signify Health, is our moderator for this session and will kick us off.
Well, thank you, Maria, and thank you, Modern Healthcare, for giving us this opportunity to engage in a discussion that we hope will help surface some questions that a lot of hospitals, health systems, physician leaders, and of course, health plans, employers, and others are asking themselves. And it's my great pleasure today to moderate this panel with three of my very favorite people, Belinda Rutledge from the America's Physician Group, Dr. Marion Couch from Regents Blue Cross Blue Shield, and Dr. Kevin Bozick from the Dell Medical School. And we're going to launch directly into this panel, and as they answer, each one of the panelists will introduce themselves a little bit and what their organization does. So let me start off with maybe a broad question to lay the foundation for this discussion. And it really is about when we talk about alternative payment models, that can be a grab bag that includes a lot of things. And what we want to really focus on, I think, today are advanced alternative payment models. And so from each of your perspectives, what is an advanced alternative payment model? Why is downside risk really important? And in particular, I know to employers who are trying to push the market in this direction. Kevin, maybe from your perspective, and Belinda also, are providers really ready to take on downside risk? And if so, for all insurance types, or maybe for some lines of businesses rather than others? So let's kick this off, and maybe Marion, if you can start off with your, given especially the work you did at CMS, your general view on this.
Thank you, Francois. Again, I'm Marion Couch. I am currently the Senior Vice President of Healthcare Services and Chief Medical Officer for Regents Blue Cross Blue Shield. I also serve across Cambia, which is our holding company, and we're located in Oregon, Washington, Idaho, and Utah. Prior to that, I worked at CMS in the Office of the Administrator as Senior Medical Advisor and spent time in the Innovation Center, where I got to interact with both Belinda and Kevin as we were trying to work on models that moved upstream and tried to push forward, especially models in the specialty care realm. And then I hate to say it, but for 30 years prior to that, I was involved in medical groups, practicing surgeon, and was chair of 2 departments, so have a good experience in the provider side as well. For me, an advanced alternative payment model, I think you have to start with the CMS definition, and it's a track of the quality payment program with 5% incentive for achieving levels of payments on patients that are involved in these models. And it's really that you have up and downside risk. And the value when you do this for CMS is that you don't have to do MIPS, merit incentive performance reporting, and that actually is quite attractive. And you get a 5% incentive for achieving levels of quality for that. And so it's quite attractive to groups. And that's really, I was always part of a group that included me under their TIN. And so therefore I always was involved in medical groups that had mostly our primary care physicians. For me now, as on the commercial payer side, it's important that we offer these models to hopefully align with payers such as CMS. But I'm just going to put something else out there that I'm become convinced of now that I've been in the payer side and the provider side and then the government regulator side. There is no other path forward, Francois. I just don't see any other way to get beyond this quandary we're in with fee-for-service. And so, we even accept a broader definition. It's not an advanced payment model, but even pay for performance is important for us. And again, I mentioned that we cover 4 states, and 2 are red states, 2 are blue states. We cover states that have large urban groups and academic medical centers and integrated vertical health systems that are quite sophisticated than rural providers and providers in underserved communities. So we are very interested in regions in going forward, although later on in the talk, I'll probably mention that that's actually not uniform within my own company. I feel some headwinds there, and we're still working to show the value of it. But for me, it really, to answer your question, it is a payment model where we have shared risk. And that to me is a really important concept with moving forward away from fee-for-service.
So Valinda, maybe from your perspective and diving into this, not all physicians are the same, and both you and Kevin operate on relatively larger organizations, but we see hesitancy from many providers at taking on downside risk, but yet isn't that the whole idea behind these alternative payment models?
Right. Yeah. I'm an EVP of Federal Affairs from America's Physician Group, and our physicians are very committed into taking risk. In fact, they think they go beyond the definition of just downside risk. And Francois, they think moving into capitation and not just doing fee-for-service with the reconciliation, but actually changing the payment model is key to that change. So they're very excited about what they're seeing in the private enterprise in terms of taking downside risk. They're seeing also that the employers at first was very, very pro value-based and wanted to see it and supported a lot of PMPM models, and as Marion said, also pay for performance. But as time has gone on, our members have experienced some frustration from the employer, saying they're not seeing a return on investment as fast as they would like to see. And second, they want to see some predictability in their costs. So they're wanting to move away from just paying for performance and moving into some downside risk, with some of the providers taking some risk to be able to cap the ceiling of the cost for healthcare. So we're beginning to see a little frustration from the employer point of view to move a little bit faster because they have not seen the return on investment that they would like to see. So they want to see a little bit more return on investment and a little bit more predictability on their cost ceiling, which means that providers have to take some pretty significant downside risk.
And they're ready to do that.
What our providers are saying is they would love to do that, but there are some obstacles in their way. First of all, the commercial population has much higher variability than Medicare. When you look at a Medicare population, it's very similar. You can risk stratify it in terms of the degree of chronic diseases. The utilization, you can put it in aged versus disabled, and you're able to, it's been well researched. When you start taking risk for the commercial population, particularly at the employer basis, it can be very different in terms of a manufacturing type of basis of employer versus something that's much more service industry or tech industry. So it has a little bit more complexity about it. They need more data to be able to take that risk. And sometimes they're having difficulty being able to get that data from particularly the TPAs to be able to say, we're willing to take the risk. But from your point of view, the question, absolutely, they want to take the risk. But they're also concerned about getting adequate amounts of data to be able to do appropriate risk stratification of it.
Well, and that's an excellent point, and we're going to come back to it because it does seem to be somewhat of a barrier. And maybe, Kevin, you can give your perspective on that, and also in your past and continuing leadership roles with your peers, you're interacting with small physician practices as well as large groups, and are there differences in perspective around risk taking from your colleagues?
Yeah, sure. So let me just first of all thank Francois for including me on the panel, and thank Modern Healthcare for really the foresight to bring this topic forward, which is on the front of all of our minds. My name is Kevin Bozick. I'm the chair of surgery and perioperative care at Dell Medical School at the University of Texas at Austin, which is the first medical school that was built on a Tier 1 research campus in the United States in the last 50 years. So we have a very unique opportunity, we think, to, as my dean likes to say, rethink everything from medical education to community engagement to healthcare delivery and payment. I also serve as the physician executive leader for the musculoskeletal service line for Ascension Health, which is a large national provider, and I also am in the presidential line of the American Academy of Orthopedic Surgeons, although I don't speak today on behalf of the American Academy of Orthopedic Surgeons. I speak on behalf of myself and my own views. Having been interested in and engaged in alternative payment models for roughly the last 20 years, I think there's a very narrow definition of advanced alternative payment models that Marion pointed out is there's a definition from CMS of advanced alternative payment models. I tend to think of that as kind of the little a. And the big A really is, a much broader concept. How do we move to the next generation of alternative payment models? How do we move beyond where we've been from pay for performance to shared savings to something that's a little bit more meaningful? I think everyone on this panel shares the perspective that we put a lot of collective effort into alternative payment models, and the results have been less than really we expected for the amount of effort put in. And so I think of an advanced alternative payment model as something other than a fee-for-service payment model that engages clinicians in a way that allows them to think differently around the way they deliver care. And I think it aligns incentives of stakeholders across the healthcare system. So I think the ideal advanced alternative payment model would align the incentives of payers, purchasers, healthcare providers, and patients. And I think we have very few examples where we have seen that to date. But to answer your earlier question about where providers are, I think providers are scared, but they're also very anxious and very excited about moving beyond their current fee-for-service model, which is constraining. I think that any providers that have been engaged in alternative payment models feel that it's liberating, and it gives them the opportunity to really open up their thoughts about the way they deliver care in ways that align with the goals of their patients. So I'm very optimistic and bullish about the future, but I do think, as Linda mentioned, there are concerns specifically related to risk adjustment and concerns about how these types of payment models might impact vulnerable populations.
Yeah, and you bring up two questions, and Marion, I'm going to flip back to you, because one of them really is the ability for physicians or any group to manage an alternative payment model is having access to regular information and also transparency on historical information. And that does seem to be a barrier very clearly that exists, be it with some payers. Even Medicare, to some extent, in the Medicare bundle payment program, doesn't necessarily release all of the information at time. It's packaged on the back end. And we see this with some of the private sector efforts. So first, Marion, from your perspective, that dual role that you've had and you have now, how is that potentially different now, and how are payers thinking potentially, hopefully differently, about releasing all of the needed information to providers? But also, the other, to me, essential issue is the way in which, and Kevin kind of alluded to this, is at the end of the day, for anyone to participate on an ongoing basis in an alternative payment model, and I hate to use this because it's overused, but the juice has to be worth the squeeze. And if you squeeze all the juice out, as has been the case in some alternative payment models, and there's nothing left to give, and that there's no incentive for continued reinvestment by the provider organization, and there's really very few incremental savings that can be done. So let's see if we can tackle both of these issues.
Thank you, Francois. The issue about sharing data is huge. And it was literally an epiphany for me while I was at CMS, because I couldn't understand why I would go into a value-based arrangement even while I was there, because it felt like gambling. At some point, a year later, some payer, CMS or someone else, would tell me if I'd made money or owed them money, and I didn't have a way to correct things or fix things or change things. So this concept, and this is my term, it's not the right term, but it's called a shared dashboard. In other words, sharing the agreed upon metrics, per member per month spend, utilization, use of specialists, how you're doing on each of your agreed upon quality metrics, and at different sites, so that you can have iterative learning and go back and fix things so that you're going to win. This is huge, and it makes providers not feel like they're gambling. And I think CMS is on the way now. They've gotten it. When I was leaving, they had really understood that and were working to fix that. And my understanding is they have brought on a vendor that will do that type of work. And we're working on it at my company as well, because we feel that this is essential to get providers to be interested to work with us. And we agree with it. We're struggling a little bit with the technology of it. It's not a trust issue, I'm proud to say. We want to share that data, but we're just trying to figure out what it looks like. And sometimes there's a Goldilocks to that. In other words, some of my colleagues want to give like a technology environment so that you can run analytics. And I'm like, no. I don't know that everyone wants to run analytics on our platform. They're going to have their own. I just want to make sure we have agreed upon idea of what we're sharing so that you can change things, you can win. Because we actually, just for the record, want people to win and earn all their quality. We budget for it. We budget so that providers would win all their quality metrics and be paid out. But we're finding that because we're not sharing it, it feels like gambling, and it's not really working in that way. To answer your second question, this work is hard. And so when I look back at the 10 years the Innovation Center has been in existence, they've learned a lot. And I'm a glass half full kind of gal, but we've learned a ton. Valinda did Strong Start when she was at the Innovation Center, and the lessons from that in the maternal space are huge. And we just have to be more intentional about learning what works, getting our contracting better, getting our benchmarking better, figuring out the technical aspects that make this work, in addition to building trust, again, with shared dashboards. And then I think we can move forward. And then with Kevin's great leadership, we can move upstream and really change the way we deliver healthcare. A lot of that is predicated on I'll just say it, this is Marian speaking. I think that CMS, because of the way they have to reduce costs and increase quality, they try to ratchet down costs, and their benchmarks get tougher and tougher every year. You're right. In the commercial sector, we don't have that. We'd love to write a contract with you and not touch it for 6 years. And I sort of think that's the way to go. And I do hope CMS learns from that. We're disincentivizing great systems that are already low in total cost and high quality. And I think that's a problem. I know Kevin agrees with this. We like topped-out measures at Surgeon. Every operation ought to have the same excellent outcomes. And if I achieve 100% every time I have an episode of care, that's actually a great thing for the system. We don't need to remove topped-out measures. So it's a different way of thinking, and I think there's an evolution at CMS. I would encourage them to do that. Leave things alone. Let people learn how to play in this space for a significant amount of time. I'll stop after that, but I do think the shared dashboard and leaving things alone for a while will be very helpful in moving forward.
Well, and in the private sector, Marian, isn't leaving things alone for a while generating savings to an extent? Because if you freeze a price for 4 or 5 years, you're effectively protecting yourself against inflation, which, you know, in the private sector, unfortunately, is certainly higher than it is in the Medicare space. But that's a formula for savings without having to ratchet down, isn't it?
I think so. So I think a lot of this is an artifact of what you need to achieve with a model at CMS, which is hopefully decrease cost and increase quality. At least you can't have decreased quality and increased costs. But I think it's an artifact of that, the way it was set up. But again, yeah, leave it alone. Let people learn and give them time to get their teams organized and get used to a new way of delivering care. I really would recommend that to Medicare.
Yeah, and Belinda, I was on a call the other day with one of our mutual friends, my mom, and she basically reminded me that some of your members have been at this now for a decade, have achieved substantial savings off of their initial benchmarks, are being rebased continuously, and now on top of it, if they migrate from their existing program to a new program. And the new program baselines them again on their current achievement. Their starting point ends up by being ridiculously lower than the market average. And so, where do you go from there?
Right. And I think, Francois, Kevin, and my article and your article that was just recently in the American Journal of Managed Care, and I think we're going to put the link up. Talks about the problem about going with historical benchmarks, that it really does disadvantage the high performer. So the most efficient high performer providers that we have, both in health systems and at physician practices, you will find for the most part, they find it difficult to particularly be in the CMS models. Because they're starting with historical. And if you started with something like what we referred to in the article in terms of a clinical experience, you take the best practice and you figure out what that cost is. And then maybe you modify the discount for those high performers. They're not the same discount, or they're able to move to regional much faster and out of historical. But I find that when I talk to some of the leading health systems in the country and leading provider groups, they're saying they love to be in risk-based contracts with commercial plans, Marion. They love being in risk-based contracts with MA plans, but they can't make it when it's in a CMS model that starts with historical, or even a commercial plan that wants to start with historical cost because they're so efficient. So maybe we want to talk a little bit about some of the things that Kevin and you recommended in the article.
Francois, you're on mute.
I'm sorry. So Kevin, as you do that, I also want you to transition us to the next topic, which really is, and Marion knows this from her work at Regents and the very clear mandate that employers are giving all of the third-party administrators they work with. We got to move to outcomes, right? We have to move to patient-reported outcomes. And it's so frustrating when we're running these programs to rely on proxies which are essentially the lack of defects, as opposed to truly looking at, is the patient better from the beginning of the process through the end of the process. And I think of this as both functional status changes over time and patient-reported outcomes, which can be blended in functional status. So maybe a few words on both the benchmarking, how we change that model, but also let's talk Turkey about giving the employers really what they're looking for, which is a fairly good understanding that their patients are getting better.
Thanks, Francois. I'll try to tie both those topics together. The first thing I wanted to say with respect to the last conversation is I often talk to physician audiences who say, isn't this just a race to the bottom, as you were referring to, Francois? I personally think fee-for-service is a race to the bottom, right? So by definition, the way the model's set up, the more efficient you get at doing something, the worse off you're going to be financially, right? If you're a physician and you get faster and more efficient at doing something, your relative value units are going to be rebased and revalued by the RUC. And if you're a hospital, your DRG weight is going to go down, or it's going to move from Part A to Part B. So it's built in that as you get better at doing something, you will be paid less. I think in the world of value, there is an opportunity that as you improve, not only do you get feedback and learn, but you can actually succeed both clinically and financially. But I do think it takes, as all of you mentioned, a different mindset, which is rather than just exclusively focusing on saying, boy, I'm really disappointed that we only had this much cost savings. I think there are a lot of secondary consequences of the shift to value-based payment models that may or may not have borne out in terms of a return on investment yet, but I honestly believe they will. And one of them is what you alluded to, Francois, is the investment in measuring outcomes. So we as providers really never had any incentive to measure outcomes and measure the outcomes that matter to patients. The CJR payment model, which is a mandatory bundle payment that Medicare put in 2016, had a quality incentive for measuring and reporting patient-reported outcomes. Now, a lot of people would say, well, that's a process measure, not very exciting, not really tied to outcomes, but it incentivized hospitals to invest in the infrastructure to measure patient-reported outcomes. There's also been a lot more work done to develop more integrated, coordinated systems of care across care delivery sites, from primary care to acute care to post-acute care. There's better coordination and integration, and there's more active attempts at patient engagement and activation. So I think all of those things are a consequence of the shift to risk and value-based payment models that may or may not have shown up yet in terms of cost savings per episode, but I honestly believe they will. And regardless, as Marion mentioned, they will result in better health for patients. So I just think we have to broaden our horizon a little bit in terms of how we think about the success or failure of our attempts to date. Last thing I'll say, because I'm going to let others talk, is around the patient-reported outcome issue. I honestly believe the reason why we've had so little traction and uptake is because there are so few use cases out there for how do you use patient-reported outcomes in your daily life as either a patient or as a physician. And so, we've built them into predictive analytic algorithms that are used by patients and their physicians in shared decision-making conversations. You can use them in performance improvement, but if all you do is collect the data and stick it in a file somewhere and look at it once a year, it's unlikely to be seen as worth the effort or the juice being worth the squeeze, as you said, by both patients and providers, which is why I think we need more use cases before we're going to see more uptake of patient-reported outcomes in routine clinical practice and payment.
But I want you to also hit on functional status, because I over the years, and you and I have talked about this, if I'm an employer and I've got employees with low back pain, and I know that the evidence strongly suggests that having back surgery should be done really on a very small subset of those patients. And yet it's just been really hard for me to get any consistent information on if my employee is going to a physician for management of that low back pain, are they improving over time? Is their functional status getting better? Because at some level, just even in more than academically, if I'm tracking that, and if there's a reporting aspect of it, then if the patient is getting better, then okay, why are they getting surgery? Or if the patient really truly isn't getting any better, and in fact, their pain management is getting worse, their functional status is getting worse, then yes, there ought to be potentially a surgery, and I ought to be able to see after the surgery that there's an improvement in functional status. Otherwise, what was the point? And is the provider community ready for that, or is there still hesitancy that, if I open up that Pandora's box, we're going to be in trouble?
Yeah, I mean, I don't think so. I think the provider community is ready. I think that we need to perfect the infrastructure and make it more seamless and integrated with the electronic health record. But you make a very good point. I'm a surgeon. I do hip and knee replacement. And when I talk to surgeons about risks of surgery, you talked about the critical defects and things like mortality and infection and DVT. I mean, hopefully those are extremely low, and those are, that's the floor. That's, safety is sort of assumed. Ultimately, what I tell my patients is far and away your biggest risk is you're going to have a major operation and not achieve better function and less pain than you have coming in. That dwarfs all of those other risks that we talk about. So it really takes changing the mindset. And honestly, when I talk to patients, they're shocked to hear that there's even a possibility that they won't achieve their functional goals in pain. And so I think it really takes all of us rethinking how we discuss these things with patients. And I think it takes payers and purchasers holding providers accountable for functional outcomes and making that, part of the expectation of routine clinical practice.
And Marion, as you kind of comment on that and the importance, from your perspective around patient-reported outcomes, functional status, how do you see the next decade evolving for regions and other payers in this field? How do we get more APMs, more momentum, and ultimately, better transition of the delivery system?
Great question. I'm fond of saying to my colleagues, because not all of them, even in my company, are completely sold on this concept of value-based arrangements or value-based care. I'm like, okay, then tell me what the other path forward is, because this isn't working. We're sometimes we fight over unit costs and discounts, and it's just this, and there's no path forward in that. If we keep doing that, we're not going to evolve, and we all have to evolve. The other thing I would say to you, Francois, is we have to build a great provider network. We unlike CMS, in a way, we have to compete for that. We have to work for that. We have to earn that provider network and earn that relationship and be a partner of choice. It's huge to us, and it's a competitive advantage, and we need to do it. And I'm very hopeful that we are seeing people think about, all right, fee for service was not so great. And I would say one other thing about Kevin's secondary outcomes of value-based arrangements, it lets physicians practice medicine in a way that we were trained to do, and there's great value in that. And this prior auth stuff is because we don't trust each other, and a lot of that goes away when you are partnering and they're assuming risk for that. And it's a huge concept. If burnout is a huge issue and prior auth is the number one frustration for clinicians, I mean, we're all fools if we don't address that. So for us, it's a competitive advantage to work with providers. And for me, it's a way to say, listen, we're partnering with you. How can we work with you? And again, as I started to say, my hope is coming out of the pandemic, people really see that fee for service did me no good. I'm gonna partner with someone so I have revenue coming in, even if it's just for economic reasons that they want to have a per member per month relationship with us. But my hope is that we're in a new time, a moment in time for transformation. But we need to differentiate ourselves in the market. And that's why I'm pushing this, is because it's the only path forward I see. And it helps me have our company have a competitive advantage when we go out and try to have joint products in the market and differentiate ourselves. And my hope is that members feel that, that at the end of the day, when my physician, and they have a team around them, because that's, again, what Kevin and Belinda always advocated for, you're putting a payment model on innovative healthcare delivery innovations. That's the key thing. We're going to pay for not just the same thing, but innovations in the way we think about episodes of care, and you have a delivery team. And one of my biggest motivators is one of Kevin's very colleagues in one of the great organizations he's part of said, Marion, I'm so tired of giving a knee operation for someone who's depressed. We have to have ways to really suss out what their outcome is and how we can get them the outcome they want. And it may not always be an operation for in that case. So I just think it's, again, to go back to answer your question, it's a competitive advantage. And that's why I think it's going to work. And that's why I remain very passionate about it.
And Belinda, maybe last minute of comments, it's also a competitive advantage for your groups, right? And so how do you see that evolving over the next decade?
Yeah, so from a physicians group perspective, they feel that, as Kevin said, that fee for service and moving and focusing on volume is just not sustainable, particularly with us, not only in the Medicare space, with Medicare looking like it's going to be insolvent by 2024, 2026, depending on who you're talking to to the amount of gross domestic product that is now being used on healthcare in our industries. We've got to move, as Marion said, what's the alternative? We have to move away from this fee for service. And the only way we can do that is, one, I think moving into risk-based models, but two, actually changing how we're paid. I'm a big believer, as I said at the beginning, moving out of fee-for-service into capitation. That allows you to have money on the front end to be able to put some of this money that you need to in building some of these infrastructures, the care coordination, the virtual models that are needed. It allows for some of this innovation that is beginning to take effect that we've seen through the pandemic. So our members in APG are big believers, and we saw it happen during the pandemic. Let's take advantage of it and let's move out of fee-for-service.
Well, look, I know we could probably spend hours together on this, and we certainly have in the past, and I want to thank you. I also want to encourage the audience to read the piece that Valinda, Kevin, and I co-authored in the American Journal of Managed Care. There's a PDF attached to today's session. And now let's turn it to the audience and answer their questions. Great. So thank you again, Valinda and Marion, for a great conversation. And we're joined by a number of participants live today. So let's start tackling some questions, and one in particular around behavioral health, because in the prior comments, Marion, you mentioned, quote from about number of plan members who end up by getting orthopedic surgeries, but who are still depressed even after the procedure because ultimately it didn't necessarily solve their problem. We're also seeing, coming out of the pandemic, just an absolute crazy exacerbation of behavioral health issues with people of all ages, genders, races, and that's a piece that oftentimes gets left behind in the thinking around value-based payment. We talk about medical, chronic conditions, procedures, but we don't often talk about, and certainly not enough, about behavioral health and mental health. So maybe starting with you, Marion, how do we add that to the mix?
Francois, great question. We are working to include not only behavioral health, but other groups, specialties in risk-based and value-based care. And I think it's an important thing to think about. And there are companies out there innovating that have approached us about being part of a value-based arrangement in the behavioral health space. But I think we're still, I think many of us are still working on moving into risk-based arrangements, and the specialty models are coming. And certainly you play in that area, but the specialty models are coming. I have confidence they'll be there, but I'm seeing demand on the commercial vendors side that have products, and we have to start thinking, I think probably many of the commercial payers, on how we could utilize that. We're not, I would say I'm not seeing that we're quite there.
Yeah, and Valinda, this goes to some of the questions that have come up around the tipping point, because ultimately the tipping point to move from fee-for-service to value-based payment is the scope of what you can include in value-based payment arrangements. And with some colleagues, we did some back-of-the-envelope calculations the other day, and we can easily capture 75%. I mean, if you think of the outside of total cost of care and the things that sometimes are really difficult to manage, 75% of medical spend is clearly manageable. That includes mental health, behavioral health. It's difficult to disassociate. So is that the formula, is just ensuring that when CMS comes out with models, that you end up with a much bigger pot that has to be met? And same thing in the private sector?
Yeah, so I have to tell you, Francois, I get this question a lot from people. When do we move from fee for service to value based? And I always say, okay, my first question to you is, do you currently make money in Medicare patients? And they go, no, I lose money on all of it. Then to me, you've got to move out of fee for service into risk based, because that's the only way you're going to be able to change how you deliver the care and get some savings to compensate for the loss on every single Medicare patient that you have. So to me, that's an easy question to answer and to ask yourself when you're moving into Medicare. Now, as the system as a whole, that is a bigger question, moving the whole system and turning it from a fee-for-service bricks and mortar into a value-based. That has to be a much more deliberate move. That has to be representative of where you are in your market. How many payers can you move into it? People are finding that MA plans are very open in terms of having that conversation with the providers. So if you can get Medicare fee-for-service and MA, and you start moving, and then you go after the commercial and employer-based to then have that third, you certainly want to have a strategy in which you are moving all of the payers into one direction. You certainly want to have a strategy in which they all have similar quality measures, so you don't end up with 25 different measures, because that's going to be additional cost to you. But in terms of the simple question, should I get involved with a CMS risk-based contract? My question is, do you currently make money on a Medicare fee-for-service? And if you don't, you need to get involved, because that's the only way you're going to compensate for that loss of every single Medicare patient that enters your system.
Yeah, and that certainly jives with what Kevin was said, who, by the way, is in the OR, so he can't join us for this portion, that fee-for-service is more or less the race to the bottom. And so there are ways of structuring alternative payment models that don't meet that. And I want to get to some of the questions that were focused on primary care, because I think for all of us, and and Medicare Advantage and the plans, to your point, Valinda, I think have done a good job at kind of looking at how do you engage primary care? How do you engage specialty care? How do you engage acute care providers, post-acute care providers, and really stitching payment models together nicely for the Medicare Advantage population? There's no fundamental reason why it can't be done in other lines of business. And I do know, Marion, that employers and certainly Regions as a plan tightly focused on this combination of engagement of primary care, plus whether it's near site, on site that the employers love, or just general primary care and the specialty care that we talked about. So to me, it's not an MA issue. Right, Marion? I mean, it's...
Yeah. No, I think that's right. I do agree with the way Valinda thinks about approaching it. That makes a lot of sense to me, but right, we have to move past it, and I would agree with that. Yeah.
So primary care, and I know there was a question about the Oak Streets and Village MDs and some of these other groups, and I don't see them, by the way, exclusively operating in Medicare Advantage. IR is a good example of a organization that operates in under 65 commercial insurance. So to me, it's primary care transformation is part of delivery system transformation, and including them in alternative payment models is just a normal par for the course. So maybe one last question about that came up here about Haven. We all know that those three companies decided to call it quits. And I have my own opinion, but to me, it doesn't signal in any way, shape, or form in either a reversal or a reduction in the speed of advancement of alternative payment models. I think it speaks more to the difficulty of private sector organizations, companies who have very different employers doing different things. And aren't health plans there to aggregate lives across employers? So isn't that the better solution?
Right.
I mean, Valinda, go ahead, Marion.
Well, I think people are always surprised when you enter into the healthcare industry how complex it is. And it's like a sweater. You pull over here, it's going to unravel things over there. And so I do think that trying to work and innovate with commercial payers and align with CMS, as Belinda pointed out, make sure you're harmonized so it makes sense to the providers is a great way to go. Those companies that you mentioned that are innovating, wonderful. No, I think we need to innovate our way out of this. We can figure out how to integrate them into our system, but I agree with you. The failure of some companies is just because healthcare is hard. Something I said earlier, we need to learn. And I think, again, aligning, multi-payer is huge, a huge concept.
And that answer is also, I think, for your members, Valinda, the complexity of dealing with multiple programs, multiple payers, multiple lines of business. The more we can get Medicaid, Medicare, private sector to harmonize some of these APM efforts, the better for everyone.
Yes.
Thank you,
Can I make?
Oh. Yes.
I was going to make some comment real quick. I do think as we have evolved in new technology like hospital at home or telehealth, remote patient monitoring, we're going to need new payment structures, or we're going to be lost in what are we billing for and how do we prevent overutilization of telehealth, which is this big conversation going on in Congress right now. When you're in a risk-based contract, that allows us the freedom to redesign care using this new technology and not have to be so focused on what is going to be the code and how much we're going to be paid for this. So I think moving to an alternative payment model allows us the freedom to take advantage of some of this new technology we're beginning to see, and it's so exciting.
Great. Thank you guys so much. That takes us to the end of this session. Thank you to our esteemed panel and our lead sponsor, Signify Health, for this panel discussion.